Thank you for having me here. I will go as quickly as I can through the material and try to get us back onto schedule for going home. My objectives are really to talk about a few things. I want to talk about the characteristics of a crisis event. What defines a disaster? And the variables of a disaster situation that really impact how traumatizing it might be for children and teens. I want to talk about what are typical, common, expected responses to trauma and what are problematic responses and how we can know the difference between those two. We'll talk a little bit about triage, psychological triage, and then just give you an idea of what are some of the major types of mental health interventions that are provided to children and teens after a disaster. Okay, first off, why do we consider mental health issues when we are considering how to help people after a disaster? Well, it's been said that the psychological footprint of a disaster greatly exceeds the medical footprint. Why is that? The people who are most directly medically involved are going to be emotionally, psychologically traumatized, but a whole host of other people will also be impacted by what has happened. Family members of the people who are injured, people who were close to this event and witnessed these life-threatening events will be impacted. People who are treating the victims of a disaster event can be impacted. So there are many layers of people who will be impacted emotionally, psychologically, and usually that number exceeds the number of people who are medically impacted. Why do we consider why do we give special consideration to children? Basically because children are seen as a highly vulnerable population when it comes to being impacted by disasters. Why is that? There are several factors. One is basically that children are dependent on adults to have their basic needs and their met, and they're dependent on us for protection. They depend a lot on routine and structure, and when things are disrupted, that alone is highly traumatizing. They have less experiential learning to figure out how do I cope with this new situation. They are very much, kids smell fear. It's been said a couple of times in these, in the prior presentations. They're very much attuned to our emotional state. So they will be impacted by how we are emotionally impacted by the events that are happening. They're basically, again, they are not mini adults. Everything that I have here in this, this presentation is part of a more comprehensive program for trying to help kids, help teenagers after a disaster, after a crisis situation that has been developed by the National Association of School Psychologists. It is called the Prepare model. Okay. What constitutes a disaster? What constitutes a crisis? Well, there are three really critical things we need to consider. One is it is something that is perceived as extremely negative. It generates feelings of intense helplessness, powerlessness, feeling trapped. And these things typically will occur suddenly and unexpectedly without warning. Sometimes, especially with natural disasters, we do have warning, especially storms. There's warning that things are, that is may be coming. So the two most important considerations are a disaster event, a crisis event, extremely negative, and generating those feelings of helplessness, powerlessness. My life is threatened. When we talk about how do we classify disasters, one of the things we consider is the scope. Is this a local event? Does it impact a school? Does it impact a town? Does it impact one community? Is it more of a regional event, or is it a national event? So some examples of that: a suicide in a high school could be a local crisis event, a local disaster event, something like a storm, Katrina, Sandy, were more regional events. Something like 9/11 was a national event. There were incidences at different parts of the country. So one of the things we have to consider in trying to evaluate a disaster is the scope. When I get called in to work in a disaster, I'm a visual learner. That's why I like this slide. So my first question is, well, what happened? Okay, so I want to know four things about the event. The predictability, was this something that we could foresee occurring? Or was this something that happened out of the blue? The consequences, how many people are involved? Is this, is this a mass casualty situation? Is this a limited, are the number of people impacted, is it limited or is it, massive? What is the duration of the event? Why is that important? Because how many people were exposed? How many people were, either directly impacted or saw the impact of this event? And the intensity, how horrific is this? How visual, how visually upsetting was this for people who were involved? And all of those four factors are going to really determine how much emotional, how much psychological devastation there could be from an act. Variables, again, that are important in determining the intensity of an event is this something that's human-caused or natural? Human-caused events just tend to be more traumatizing than naturally caused events. Is this an intentional event? Is this an accidental event? So probably the most intense would be the human-caused intentional events. Okay. So when we talk about how do teenagers respond to a crisis, we're going to be looking at two things: the normal crisis state, or the expected crisis state, and then we'll look at some more problematic or pathological reactions. The normal crisis state is a temporary state of upset and disorganization, characterized by an inability to cope with this unusual situation. And the things that we usually do to problem solve, the things that we usually do to cope, just don't work. And it causes this state of, a radical state of upset and negative outcomes. So basically, it's more than simple stress, but crisis reaction is not necessarily a mental illness. Okay, so it's more than a normal stress reaction, but it is not a sign of mental illness. This is why when you work with kids, when you work with teens after a crisis, being able to reassure them what normal crisis reactions are is very helpful, because people feel like, I'm not coping well, there's something dramatically wrong with me. This doesn't feel normal. So when you can tell kids, when you can tell teens, when you can tell parents that these reactions, a day, a couple of days, up to a week after exposure to an event like this is normal, it can be very comforting to them. All right, so we'll look at what are typical crisis reactions in terms of emotional reactions, cognitive reactions, behavioral reactions, and physical reactions. The list is there for the emotional reactions. Again, we see a lot with kids, the shock, the shock and numbness. The things I see the most are really over-emoters. People who just cannot contain their emotion. They are going to be, if it's anxiety, they're going to be panicked. They are going to be, they can't sit still. They're going to be crying. They're going to be very visibly upset. Or some of these kids who are in shock, and you see no kind of, no emotional reaction. That very much the emotional numbing. But these are some of the very common, very normal emotional reactions after a crisis. The physical reactions, they're really the things that happen when the stress response has been on for just too long. All of those kinds of things like fatigue, pain, the GI problems, the decreased appetite, for teens, the decreased libido, hypersensitive startle response, hyperarousal, all of those things that happen when our normal fight or flight response has just been turned on for too long. cognitions, a good amount of confusion, a lack of concentration, the intrusive thoughts, you know, people who are trying to distract themselves, they're trying to get back to normal functioning, and thoughts of this event just keep intruding back in, just keep coming back in. Memory disruptions, nightmares. These are, again, in the days, the hours, the days after exposure to a crisis, these are normal reactions. Behavioral reactions, easily crying, social withdrawal, that, you know, that not responding to others, people who want to avoid reminders of the situation where they encountered a crisis, you know, functional problems, kids who are having trouble going back to school. Probably one of the things I see the most in terms of behavioral reactions is increased separation anxiety. Kids who do not want to leave home. They want to, you know, they have a hard time going away from their primary caregivers, their comforting places, and sometimes a lot of aggression. Okay. So these crisis reactions, these are long lists. What are you going to see in a particular child? Well, for kids, the things we really want to, the real influential factors about what we're going to see and how we're going to see it are their developmental level, their family functioning, and their culture. Those are the things that are really going to impact how they react, how they respond to these kinds of crises. So let's look first at developmental level. Preschoolers, you know, again, their reactions are not going to be not as clearly connected to the crisis event. And they are usually expressed non-verbally. So you're going to see them clinging, you're going to see them crying, you're going to see facial expressions of fear, you're going to see the screaming, the whimpering. It's going to be a very visual thing. You may see kids in their play kind of playing, you know, kind of acting out, again, the trauma. Kids who are exposed to violence now having very violent play. This is their way of kind of trying to process, trying to make sense of what happened. We saw, you know, a couple of the presenters in the earlier presentations talked about behavioral regression. When kids are exposed to a trauma, they will start to show behaviors that they've grown out of. So they may be afraid to be alone. You may see thumb sucking. You may see bedwetting. You may see kids who are grabbing and clinging comforting objects that they haven't used in a while. They may be afraid of the dark again. So you will some of those developmental milestones that they've gone past will now start to reemerge. In school age children, again, their reactions are a little more directly connected to the crisis event. So they will be able to talk about specific crisis-related fears. So if this is a storm, they will be, you know, they will start to tell you, I am afraid that it's going to start raining again. We're going to have another earthquake. We're going to have another flood. I'm afraid of someone else coming into our school and trying to do harm to us. They will have very event-specific fears. Again, their reactions are more expressed physically and behaviorally. A lot of kids, you know, school-age kids, when they are anxious and they're scared, they're going to talk about a lot of physical complaints. I have a headache. My stomach hurts. You know, they're going to make a lot. The nurses in here are going to see them a lot. They're going to be coming down to in school. They're going to, you know, they may present at the doctor's office with physical reactions. Again, they may have elaborate or complex trauma-related play or art. This is some artwork from kids who after 9/11, and again, right after an event, the artwork will be very much about what they saw, and will be can again be very violent, can be very graphic. They will tend to describe over and over again what they saw, what they experienced. Pre-adolescents and adolescents, their reactions are going to be more like ours. Again, they are going to be capable of more abstract thought, so they are going to think, they're going to also talk about how this is going to play out in the future. You know, how this might impact them, a sense of a foreshortened future. again, you may see adolescence is a time of increased opposition. It's a time of increased aggressive behaviors, and that may get ramped up when kids, are upset. You have to be careful with adolescents about substance abuse. You have to be careful with adolescents, as a way of self-medicating their distress, and you have to be careful with self-injurious behavior and their self-injurious thinking. Okay, trying to predict who will struggle, who will have protracted struggles after a crisis. Again, for all the statisticians in the audience, we have the wonderful, life-changing normal curve. So most people will show resilience. What does that mean? Most people will be impacted, and they could be seriously distressed at the time of a crisis. Within days, within maybe a week, weeks, month, they will go back to pre-crisis functioning. They will show a tremendous amount of resilience, and they will be okay. And that is the norm for most people. Some people will, a smaller percentage will show what we call post-traumatic growth. This will be an experience that has positive impacts on their life trajectory. It changes them, in profoundly positive ways. They talk about being able to see personal benefits in how they see their strength, how they see other people, how they see the preciousness of life and their experiences. So some people will experience post-traumatic growth, and another small percentage of people will struggle for prolonged amounts of time. What will they struggle with? They'll struggle with anxiety disorders. They will struggle with depression. They will struggle with Florio problems. No, that's me. They will struggle with post-traumatic stress issues. So they'll struggle with substance abuse issues. Again. So these are serious concerns, and they are concerns that, as mental health professionals, we can help people with. But the point of this slide is that we can expect, with good support, with reaffirming perceptions of health, reaffirming perceptions of safety, getting kids back to their normal supports, their normal resources, we can expect that most kids will be able to weather this storm and get back to pre-crisis functioning. We can expect some to grow, but we will expect some to struggle. So that begs the sign of, how do we know? How can we try to predict who will struggle and who will just get back to normal or grow? In order to present the model, the triage model that the Prepare model uses, and that I think is a very good model, we have to talk about two things: early warning signs and enduring warning signs. Early warning signs are basically those symptoms of distress, signs of distress that we see immediately after a crisis event. Those things that we think are normal, we know are normal, and when we see them immediately after an event, we address them, but we don't get overly concerned that this might be a person who's going to develop a pathological reaction later, okay? So the only thing we're looking at there is intensity. Sometimes these early warning signs are so intense that we are concerned about a person. So immediately after a crisis reaction, if we're doing psychological first aid, which we'll talk about a little bit later, if we're doing psychological triage, we expect to see some of these signs of distress immediately after. We're looking at, we're looking at the intensity, reactions that are very extreme. Not only the extreme difficulty containing emotion, but the extreme of not showing any emotion, that extreme numbness as well. The same signs, days after, weeks after, now become enduring warning signs, because we're beyond the point where they should have been getting better. So they, now we're still seeing these. Most people are doing better. Most people are getting back to functioning, and we're still seeing kids. We're still seeing teenagers struggle. So, it's a little confusing because it's the same signs of distress. It's a matter of timing. So we're seeing them either as intense or the low level, but just longer. They're hanging around for a longer amount of time. Okay. So we need to know that for doing psychological triage. Why do we do psychological triage? Well, not all individuals are equally affected by a event. As we're going to see, it's not only the event that happens, it's the individual's perception of that event that is going to drive their reactions. So not all people are equally affected. If we miss people, we can undertreat. If someone is adversely affected and we miss them, they're not going to get treatment. The converse is also true, though. We can overtreat. We can, if people were not really that exposed, they're showing minimal signs of distress, and we start to, have them re-examining this event, and some of the treatments we'll talk about, we can traumatize people who would do well just going back to their normal supports, back to their normal environments. So we don't want to miss anybody, and we don't want to, we don't want to traumatize anyone else in our attempts to help them. Okay. Again, for the people who are visual learners like me, I hope this model helps. So this is basically our model for psychological triage. And it basically said, what happened, how was it perceived, and what are we seeing from the person? So in the kind of yellowish box on top are the crisis event variables. So we're looking at what was the event in terms of predictability, in terms of consequences, intensity, and duration. So it's what will be perceived by these kids. The second, the blue box, we call them risk factors. These are the factors that influence how someone perceives this event. And so we'll take a look at those. What are they? Well, their developmental level, their ability to understand it. Exposure. How much physical proximity did the person have to the event? Also, emotional proximity. How much emotional proximity? If I wasn't, so if I wasn't close to the event, but I have siblings who are close, I am now going to, I know it happened to, my siblings. I know something happened at a workplace and my parents work there. I have a lot of emotional proximity. On September 11th, we had a woman who was being treated in our infusion center, and her son worked in the North Tower, and because of communications being down for so long, it wasn't until about 4:30, 5 o'clock that she was able to get word from him that he was okay. She was not physically close to that event, but this was one of the worst days of her life because of her emotional proximity. Vulnerability. We're going to talk about internal vulnerabilities, qualities, traits about myself that make me more vulnerable to trauma, to not being able to cope adequately with this. And external vulnerabilities, things in my environment that might be lacking, or things in my environment that are there that are not helping me to cope. And culture. I am part of a culture, so how does what I've learned culturally impact my threat perception? So you have the event, I have my perception, and then I have the reactions. My initial crisis reactions, those early warning signs, and then the durable crisis reactions. These are all the things we look at when we're doing psychological trauma. And this is kind of a graphic representation of that. All right. So, again, crisis exposure, development, culture, and then those vulnerabilities. We talked about physical proximity, emotional proximity. I put Sandy Hook, the picture of Sandy Hook there because there was a lot, it was the intensity of that event was such that it's hardly possible to not have some sense of an emotional connectedness to that. If you had children, you clearly, had an emotional connection. But we've all been to school, and the idea of something like this happening in a place like a school, everybody seemed to be impacted. And again, that's the idea of the emotional proximity. How much can I relate on an emotional, on a psychological level to what has happened? When we talk about exposure, I like this is the population exposure model, and it is who is impacted. So you go from A, where you have the people who are at kind of ground zero. They are the people who are the victims of the of the impact. B would be people who are in this, they are not medically injured, but they witnessed this event. They witnessed, they saw the impact, the medical trauma. And in B, you also have the first responders. And you just keep walking out in this model to differing levels of exposure. Cultural factors. Cultural factors will impact people's worldview, will impact people's grief reactions. So we have to be aware of how culture can work to either help someone absorb a trauma, or may actually make it more difficult for them to understand this, to grieve this. In the work I did with kids after 9/11, I worked at a camp, and we followed kids for 3 years. And one of the things we did after, we had kids write a letter to their loved ones. And we did that during the day. They shared the letter. And then at night, we had a campfire, and they had an opportunity to throw the letter into the campfire to kind of symbolize their thoughts and their wishes going up, rising up with the smoke to them. We had one little boy who was of East Indian descent who became very upset by this, by this whole exercise, and we couldn't predict it. But what had happened was his father's body was never found. And an important part of the burial ritual is the burning of the funeral pyre. And family members actually have to start that fire. And it is kind of seen as an important part of the person's spirit, going back to ancestors and going up. And without the ability to do that, because there was no body, this whole incident was very upsetting to him. So we had the best of intentions, but really just didn't kind of predict how, again, cultural factors are going to impact how people experience everything everything they encounter, everything we do to try to help. We'll talk a little bit more, I hope, if we have time, cultural factors when we talk about psychological first aid. So, internal vulnerabilities. What are the internal factors? What are the characteristics, qualities that make it harder to recover from a disaster, from exposure to a disaster or a crisis? One is an avoidant coping style. Fear and anxiety are common reactions to disaster and crisis. And the only way past fear is through fear. And the more avoidant you are, the more reluctant you are to be able to approach that fear, the harder you're gonna, the more mightily you will struggle. Any kind of pre-crisis psychiatric issues, so kids who have anxiety disorders, depression, kids who have pervasive developmental disorders are going to have a hard time adjusting to the disruption in routine, the disruption in structure. Any kind of pre-crisis emotional, psychological, psychiatric, neurological issues are going to make it harder for these kids to kind of right the ship after a crisis. Poor ability to regulate emotion, soothing skills. We never really, I shouldn't say never, we rarely overtly, directly talk to kids about how do you soothe? Because we're all going to get upset. How do you soothe that, that distress when you get upset? So a poor ability to regulate emotions and soothe does not help people after a crisis. Low developmental level, poor problem-solving skills, and prior exposure to trauma. If you have been traumatized in the past, experiencing another crisis, experiencing another disaster, complicates it because now you're going to be dealing with the current situation, but all those memories from the prior traumatization. External vulnerabilities. There are some family factors. So kids who are not living with, nuclear family, don't have those people close to them to help them after an event, sometimes will struggle more. Kids who are going back to families where there's a high amount of dysfunction. If parents have post-traumatic stress issues, or parents are not good copers, that's going to make them, that's going to put them more at risk for developing these enduring warning signs or psychiatric or psychological issues afterwards. Ineffective, uncaring parents, poverty, or financial stress. Extrafamilial factors, families that are socially isolated for whatever reason it might be, new to an area, for whatever reason it is, social isolation does not help. So when people either lack the supports, or they perceive that they lack the supports, that doesn't help. So those are the variables that we look at. We look at the crisis event. We look at the amount of exposure. We look at the internal vulnerabilities, the external vulnerabilities. We look at culture. We look at development. And those are the things that we will, and we look at the early warning signs and what is enduring. Those are the things we will consider when we're doing psychological triage. Well, what's the time frame? Primary triage is done right at the time of the event, or before any immediate crisis interventions are done. Okay, so that is that's primary triage. When the event happens, as soon as the situation is safe and secure, and we're going in to try to help people, that's when we're doing primary triage. And so what are we looking for? We're looking at those early warning signs, and we're looking for people who know a little bit about these kids and can tell us about some of these risk factors. We're going to assess some of them, the internal qualities, but we're also, if we're in a school, we're looking to the teachers, to the guidance staff, to the school nurses. Who are you worried about? Who might have these, these external vulnerabilities? If we're at a camp, you're looking at the camp staff. They know these kids, they know these kids the best. So we're looking at those early warning signs. Secondary triage occurs when we come in now to do our interventions. We're going to do psychological first aid. We're going to do psychoeducational interventions. We may do group crisis interventions. You may work one-on-one with a child and do an individual crisis intervention. As you're intervening, you're still assessing. You're looking, are these kids getting better? We're going to talk about matching interventions to the level of risk. So we will do psychoeducation for people who are at minimal risk. And so we're looking for mistakes that we might have made. Someone who we thought is at minimal risk, but they're really at moderate risk, or they're really at severe risk. So we're going to kick them up in the process. And tertiary triage is, as the crisis intervention is concluding, who are we still concerned about? And we're going to make sure that they are linked up, hooked up with people in the community who will provide some more resources when we, as a crisis response team, go away. This is a form that I've used before, and what I like about it is it kind of summarizes everything I've said on a, kind of in one sheet. So along the first column, you have those risk factors, the things we have to assess. So physical proximity, emotional proximity, internal vulnerability, external vulnerabilities, their early warning signs, the enduring warning signs. People who are at low risk then will have the those are kind of responses for people who are at low risk. So they have an active coping style. They have good parent-child reactions. They remain pretty calm during the event. Only a few common crisis reactions. I got a lot of boxes here. I'm pretty sure this is someone at low risk, moderate risk, high risk. So even if I don't fill out the form, I will usually look at this as a way of just reminding me these are the things that I want to assess when doing psychological triage. So psychological first aid is probably the first type. It's the most general type. It's what we call a universal psychological intervention after a crisis. So it is a way of trying to meet kids, teenagers, adults, psychological, emotional needs after a crisis. And it's really appropriate for everyone. I mean, you really can't do harm doing this kind of psychological, this kind of intervention. So what is it? It's humane, supportive, and practical help to a fellow human being who has suffered through a crisis. So what do? We help them reestablish a sense of safety. We help meet their basic needs. You know, do they need a blanket? Do they need water? We're going to help them meet their basic needs. We start to listen to people. What was their experience? We offer some comfort, and then we're connecting them to information or supports. We're trying to help them meet those, meet the concerns, the issues that are coming up. The goals and actions of psychological first aid, again, reestablish safety, reaffirm your physical, meet the physical needs, help people address their basic needs, start to problem solve, and then reconnect them with their loved ones and their social supports. Who does psychological first aid? With some training, anyone can do it. I think medical personnel need very little training to be able to do this. It's good human care. And so it is given to adults and children who have been recently exposed to a crisis event, usually provided immediately after an event, once the scene, has been secured. It can be done in shelters after storms, when people are moved out of during floods, during earthquakes, when they're moved out and they're housed in shelters. Psychological first aid can be done there for days, or sometimes, depending on how many people are there, for weeks afterwards. Anywhere it's safe enough to do it. Okay, so who don't you do psychological first aid? Obviously, it's you can only do it when people are not in need of medical care, and it is not professional counseling. So if someone is just having such trouble containing their emotion, they need a more in-depth intervention, and it's not for people who are so distressed they're talking about self-harm. Again, the World Health Organization does great training in this. They have some great pamphlets. They have great online resources, and they talk a lot about how our nonverbal behavior. Whenever we're interacting with someone, what we say is important, but how we are is even more important. How we are with them is, I think, the most important part of establishing that empathic connection. And so they talk about some nonverbal behaviors, listening and touching, our choice of language, how you take into consideration gender, how you take into consideration culture, how you take into consideration religious beliefs. There is a lot of good information out there. In 50 minutes, I can't give it to you all. I usually do this. I've done this. I presented on this topic in either 2-day or 1-day conferences, never in 50 minutes. So my New Jersey is coming out. I'm talking very fast, I know, but I'm trying to cover as much as I can. Okay, so what we need to do after the triage and after psychological first aid is decide who needs further intervention. I'll talk to you a little bit about those further interventions, what they are, so that you know if you send somebody on or if you bring somebody in to do these things, what are you bringing people in to do? It's always helpful to know if someone's coming in and working with my patients, what are they going to do? I want to know a little bit about who I'm bringing in and what to expect. So we have different tiers of interventions. What we call universal crisis interventions, like something like psychological first aid. But we may also do interventions like psychoeducational interventions, when we will work with kids and teenagers and talk to them about what are normal reactions after a trauma. We may work with their parents, do psychoeducational interventions with them. We may do interventions to reestablish social support. We may do interventions to reaffirm physical health or safety. So these are called Tier 1. They're provided to anyone who may, they're offered to anyone who may have been impacted, who may have been at the, mildly impacted, who's judged to be at low risk. Tier 2 interventions are for people at moderate risk or above. Okay, these are people who have they were more proximate, either emotionally or physically to the event. They're showing more signs of distress. And we'll talk about group crisis interventions, individual crisis interventions, and those are the types of things that people in Tier 2 would get. Tier 3 are more traditional psychotherapeutic interventions. These are the people who are, just very much impacted, showing, troubling, concerning signs of distress. Psychoeducation, again, this is the provision of direct instruction, direct information to help people cope, to help them understand, to help them be prepared, to help them feel empowered. Knowledge is power. And so psychoeducational interventions are interventions that give people that kind of knowledge, that kind of power about coping, about normal reactions. They can be done with handouts. They can be done in letter forms. They could be done in caregiver trainings. They could be done in group meetings with kids or teenagers. There are a lot of resources there that there's no need to reinvent the wheel. National Association of School Psychologists, has NASP online, has a whole host of PDF documents that just need minor adjustments to make it more specific to the specific type of crisis. But they talk about normal crisis reaction. They talk about coping. They talk about dealing with anxiety and dealing with stress. They talk about grief. There's very good resources that just need minimal tinkering with. There's no sense reinventing the wheel. There's a lot of good resources out there for psychoeducation. The limitations, again, it is most helpful for people who are at low risk to moderate risk. It is not sufficient for people who are severely traumatized. An individual disaster intervention is something we do. It's an active intervention. It's something we do to help facilitate adaptive coping or to directly respond to the symptoms of traumatic stress. So it's more than just trying to educate. It's something we actively do. One of two goals: help them cope or reduce a symptom or a sign of distress. There is a lot of good information about how to deliver these. There's a lot of good training about how to deliver these kinds of interventions. A group disaster intervention is a disaster intervention, again, people who are moderate, at moderate risk or above, but this is done with a group. So, for instance, if there was an automobile accident, with multiple casualties, kids from the class that the people who were either injured or who, if there were fatalities, you might do a group crisis, group disaster, group crisis intervention with the kids who were in that class. You would probably exclude their close friends. You at least offer them the ability to get more services because they are at high risk. But again, these are things you would do to help people in groups, classroom meetings, groups of people who have like exposure. That's the important thing here. You can have people in these groups that have varying levels of exposure. They have to be homogeneous groups, and you can have groups that are traditionally antagonistic towards each other. Again, you can get there's a lot of good information and training on how to to do these. If you are a mental health professional and you want, you want to get more involved in this, there is a lot of good training that will take advantage of your skills, take advantage of your experience, and teach you how to do these. Trauma-focused psychotherapy. So for people who are needing more than these interventions to help them cope, to reduce symptoms, they need to reintegrate after this trauma. They have to figure out how to incorporate this into their view of themselves. They need to incorporate this into their view of how the world works. That's longer work, and that is sometimes done in psychotherapy, helping to deal with PTSD, helping to deal with substance abuse, helping to deal with depression or anxiety. And that is typically done with cognitive behavioral therapies. They tend to have the best efficacy data out there. So these are some of the kinds of therapies that if you refer patients to, you refer kids and teens, these are most likely the types of therapies that they will get. And then there are also psychopharmacological treatments that can help people who are having severe severe emotional symptoms, who are having disruptions in their functioning because they are having difficulty coping. And they are used in conjunction oftentimes with the psychosocial interventions. I apologize for talking very quickly. I think we're getting close to being back on schedule, but if anybody has any questions, I'm happy to try to answer them. I have your microphone. Yeah, so the question is, the military is doing some training, some coping, training in specific types of coping mechanisms to reduce the incidence of PTSD for soldiers. And the question was, are there similar things being done in school? And yes, there are. Most of them are, again, built on trying to develop these more approach-oriented coping behaviors, more emotional regulation. The data, I have to be honest, the data with anyone, with adults and with kids, in trying to prevent PTSD is equivocal at best. The data on trying to predict who's going to develop PTSD is equivocal at best at this, at this point in time.